Welcome to the Tissue Transfer, Flaps, and Grafts course. In this course, you will learn about the different types of flaps and grafts, as well as flaps and grafts coding tips. Click the Let's Begin button to start your training. Flap surgery is a technique in plastic and reconstructive surgery where any type of tissue is lifted from a donor site and moved to a recipient site with an intact blood supply. Grafts are harvested tissue and initially ischemic, meaning restricted in blood supply. Grafts survive off of local tissue and rely on the growth of new blood vessels. In addition to skin, fat, bone, and tendon can also be used for grafting. Click the right arrow button to learn more about flaps. There are as many types of flaps as there are types of injuries that might require the use of a flap. When choosing to perform a flap procedure, there are many considerations that the surgeon must take into account. First, think about the primary defect or flap recipient site. What is the location and size of the defect? What is the quality and vascularity of surrounding tissues? Presence of exposed structures? What are the functional and aesthetic considerations? Next, consider the secondary defect or donor site. What is the location from which the flap will be taken? What type of tissue is needed? What are the functional and aesthetic considerations? Click the right arrow button to continue. There are three common types of flaps: local flap, regional flap, and microvascular flap. Click each button to learn more. A local flap involves adjacent tissue transfer, which relocates a flap of healthy skin and subcutaneous tissue from a donor site to an adjacent laceration, scar defect, or other discontinuity. A portion of the flap is usually left intact to enhance its blood supply. Adjacent tissue transfer and rearrangement, or ATTR, may be performed for repair of traumatic skin wounds, lesion excision, or rearrangement, reconstruction of tissue by Z-plasty, W-plasty, VY-plasty, rotation flaps, advancement flaps, or other methods. Flaps described with adjacent tissue transfer codes 14000 through 14302 require a skin incision, advancement, and/or rotation into a defect and result in a secondary defect which must be closed. To see a visual representation of this type of tissue repair, click the right arrow button. Take a few minutes to review the information shown. Then, click the right arrow button to continue. For adjacent tissue transfer current procedural terminology, or CPT coding, the surface area measurement used to select the appropriate code is that of the total defect. Area is measured in square centimeters and obtained by multiplying the length times the width of the wound. The total defect is the sum of the primary defect, which is the surface area of the original defect, plus the secondary defect, which is the surface area of the defect created by flap elevation. These procedures include excisions at the same location. For instance, an excision may be made to revise a scar or to remove a benign or malignant lesion, with an ATTR used to close the wound. Do not report debridement codes with adjacent tissue transfer codes for the same lesion or injury. Take a few minutes to review the CPT coding table shown, then click the right arrow button to continue. These procedures include excisions at the same location. For instance, an excision may be made to revise a scar or to remove a benign or malignant lesion, with an ATTR used to close the wound. Do not report debridement codes with adjacent tissue transfer codes for the same lesion or injury. Adjacent transfer codes can be billed in addition to the excision of soft tissue tumors or bone tumors. Grafts and flaps used to repair secondary defects are separately reportable. The adjacent tissue transfer codes are not to be used for direct closure of traumatic wounds incidentally resulting in these configurations. Undermining of adjacent tissues does not constitute advancement flap closure to be reported with adjacent tissue transfer codes. Undermining is reported as a complex repair within the CPT 13XXX code series. Now, let's take a short break to check what you have learned. Click the right arrow button to answer 3 knowledge check questions. Let's take a break and check what you've learned. Click the right arrow button. When choosing the right flap, surgeons must first consider the primary defect, known as the recipient site. Location and size must be considered along with the quality and vascularity of surrounding tissues. The presence of exposed structures must be taken into account, as well as functional and aesthetic aspects. The secondary defect, which is the donor site, considerations include the location and type of tissue needed, as well as functional and aesthetic needs. Click the right arrow button to learn about specific types of flaps. The regional flap is a very common type of flap. Let's take a closer look at two subtypes, myocutaneous flaps and fasciocutaneous flaps. A myocutaneous flap is a compound flap of skin and muscle with adequate vascularity to permit sufficient tissue to be transferred to the recipient site. A fasciocutaneous flap includes skin, subcutaneous tissue, the layer under the dermis that is used for fat storage, and the underlying fascia, or deep tissue enclosing a muscle. This type of flap results in a more robust blood supply and the ability to fill a larger defect. The CPT codes for regional flaps describe extensive procedures, including the creation of a pedicled blood supply and transfer of named muscles. Codes are reported based on the donor site of the flap. For myocutaneous or fasciocutaneous flaps, use CPT code 15733, a new code created in 2018 for flaps with a head or neck donor site. This may involve, for example, one of the following muscles: temporalis, masseter, sternocleidomastoid, and levator scapulae. The pedicles listed in code 15733 are the only pedicles that apply when reporting this code. For flaps with the donor site in the trunk, use code 15734. Use code 15736 for the upper extremity, and use code 15738 for the lower extremity. Muscle flap codes are based on the donor site. For example, a pectoralis flap to the head is coded 15734, and a leg-based flap to the pelvis is coded 15738. Muscle flaps coding should also be based on the axial pattern blood supply. Even though a flap may have a muscle or fascia in it, the flap is not necessarily a muscle or fascial flap as described by CPT codes in the 15733 to 15738 range. Random pattern flaps that include small amounts of muscle or fascial tissue should not be reported with these codes. Additionally, when performing random island, Z-plasty, W-plasty, VY subcutaneous, advancement, rotation, and all other flaps from adjacent areas that do not have clearly defined anatomically named axial vessels, the adjacent tissue transfer or rearrangement codes 14000 to 14302 are to be used. Click the right arrow button to continue. Documentation must support preservation of axial blood supply of the flap, including identification of the artery and vein. For bilateral muscle flaps, report the same code twice and may need to include modifier -59. Some payers may want modifiers RT and LT. For true perforator flaps in the head, neck, trunk, upper, or lower extremities, consider using modifier -22. Codes in the 15570 to 1577738 range do not include extensive immobilization. As such, plaster casts or other mobilizing devices may be reported separately. Use the appropriate modifier and note the reason for the immobilization. Now that we have discussed pedicle flaps, let's return to another common flap type, tube flaps. Click the right arrow button. Although they are rare, another type of flap is a tubed flap. With a tube flap, the tissue remains attached at its base, the pedicle, and includes blood vessels that enter into the flap from the donor site with plans for later division. This involves a multi-stage procedure. During the first stage, the tube is formed and the base maintains a blood supply. The second stage is called the transfer stage, and it is coded 15650 for any location on the body. In the third and final stage, the flap is divided and released once it has established a blood supply from the recipient site. The patient returns on a different date of service for the second procedure, in which the flap is divided and then inserted into the defect. The first and third stage are coded according to the recipient area, as shown in the table. If division and inset of the flap within the global period of the first stage, use modifier -58 to indicate a staged procedure. Review the information in the table and then click the right arrow button to continue. A separate code, 15731, had been created to report the first stage of a forehead flap. For the final stage, or inset, the forehead flap code is 15630. Primary closure of the forehead donor site is included in the major code 15731. Click the right arrow button to learn about other flaps. An island flap typically involves the skin or fascia being attached to an isolated blood vessel and then transferred. The flap is typically transferred through a tunnel underneath the skin and then sutured into its new position. The donor site is closed directly, and the code used for the island flap is 15740. However, for random island flaps, VY subcutaneous flaps, advancement flaps, and other flaps without a clearly defined blood vessel, use code range 14000 through 14302. A neurovascular flap serves to re-innervate a damaged portion of the body dependent on touch or movement, such as the thumb. Code 15750 should be used for a neurovascular flap. Click the right arrow button to continue. Microvascular flaps, also known as free flaps, require microsurgical repair of blood vessels after transfer to reconstitute vascularity. This surgical joining of blood vessels is known as microvascular anastomosis. The procedure also begins with evaluation of the flap and isolation of donor and recipient blood vessels. Next, flap transfer and microvascular anastomosis take place, followed by inset of the flap and direct closure of the donor site. It requires the use of an operating microscope for the connection of one artery and two veins. Microvascular muscle or myocutaneous flaps are given the CPT code 15756. Microvascular skin flaps are coded 15757, and microvascular fascial flaps fall under the 15758 code. Click the right arrow button to learn about another kind of free flap, an osseous free flap. Osseous microvascular flaps are composed of or contain bone. The transfer of an osseous free flap involves all of the components of soft tissue microvascular flap codes plus osteointegration, the firm anchoring of a surgical implant by growth of bone around it. This procedure is performed in dentistry and bone surgery. Review the tables shown for microvascular bone grafts and microvascular osteocutaneous flaps. When finished reviewing the information, click the right arrow button. Code separately for harvest of a graft to close the donor site. If there is a need to return to the operating room to repair a clotted vein, refer to codes 34401 to 37999. Do not separately report a code for vessel dissection or separately report a code to reflect testing of vascular flow. Both are included in the microvascular flap transfer procedure. If attached muscle or skin flap is harvested and transferred with free flap and inset to an adjacent but separate defect, this is known as a chimera flap and should be reported in the 1573 series with a reduced service 52 modifier because both flaps have a common donor site. Click the right arrow button to learn about a lymphovenous bypass. A lymphovenous bypass is a microsurgery used to treat lymphedema. Lymphedema is a swelling, usually in the arms, caused by fluid accumulating in the tissues. In the bypass procedure, blocked lymphatic vessels are connected by a nearby vein. For lymphovenous bypass, use code 38999. When performed as a free tissue transfer, use code 15758. Now, let's review some graft codes. Click the right arrow button. Review the table shown, including graft coding tips. When finished reviewing, click the right arrow button to test your knowledge. Let's check one more time what you've learned. Congratulations! You've completed the tissue transfer, flaps, and grafts training. You may now exit the course.